Hello guys, a warm welcome to all of you. This is Dr. S. Krishna Kumar here, and we are here for the discussion of the recently concluded INI-CET May 25, particularly the physiology questions. How many questions were asked from physiology this time? I have received around a handful of 15 high-yield MCQ, and these questions are very interesting, I must say. While finding out the answers, they are highly curious. From the important topics only, obviously. It is high time, it's a very good thing that the INI-CET question setters decided to retire topics on nerve action potentials, cardiac action potentials. This time, not much of questions came from there. Last 3 or 4 years continuously, questions came from those areas. So they decided to retire those topics. But still, one age-old stalwart still remaining is constantly featuring in all the INI-CET exams, and that question is none other but the tetanizing frequency calculations. Without changing the value numbers, they are constantly repeating the same question. Very simple one. If you see this question, definitely you would have been happy in the exam hall because the answer is very obvious, simple. Chronic repeat. During a simple muscle twitch experiment, latent period 10 milliseconds, contraction period 40 milliseconds, relaxation period 20 milliseconds. What is the fusion frequency that is required to tetanize this muscle in hertz? See, they are asking about the tetanizing frequency. We all know the formula is very simple. 1 divided by contraction period. How much it is here? So contraction period is 40 milliseconds. So 1 by 40. So it is in milliseconds. We have to convert this into seconds. So obviously the answer here is very simple. 25 hertz. One of the chronic repeat MCQ. I think majority of you would have answered this question correctly. Simple mark giving question. 25 is the answer here. Now, let's move on to the next question. Very clinically oriented, very practical question also. In uncontrolled diabetes, in which of the following cells there is decreased glucose uptake due to insulin deficiency? What is the physiology concept you need to remember here? What are all the insulin dependent sites for glucose uptake? That's all. There are only 3 important regions. One among them is given here in the option. Very thought-provoking question indeed. It should be skeletal muscle. So the answer obviously here is skeletal muscle, which is one of the insulin dependent site for glucose uptake. What are the other location, guys? It is again one of the repeat topic. We obviously know 3 important locations. The major action of insulin is always to decrease blood glucose levels. How? By acting in 3 important locations. We know these 3 important locations. The first one is heart. Second one, they are in the option skeletal muscle. And third one is this adipose tissue. How it is going to decrease glucose levels? By upregulating an important glucose transporter, which is GLUT4. What is this incorrected here? This is none other but the GLUT4. So obviously from the blood, all the glucose will move into heart, skeletal muscle and adipose tissue, thereby decreasing blood glucose level. I told you this question recently also, previous year they asked the same question in a different way. So these days we always ask the people who are having diabetes mellitus to undergo regular physical activity in the form of exercise. Exercise is beneficial in what way, guys? Because this exercise by itself, by activating certain molecular mechanisms, can upregulate GLUT4. And what is that molecular mechanism, sir? Exercise is going to activate something called as an AMPA kinase pathway. What is this AMPA kinase, sir? Adenosine monophosphate activated kinase, which is our AMPA kinase pathway. The most important point is here, this action of exercise, this beneficial effect of exercise is independent of insulin. Upregulating GLUT4, remember, the concept is we always need insulin for upregulating GLUT4. But recent research evidence suggests that this exercise by itself upregulates GLUT4. This action is independent of insulin. That is why diabetic individuals, in general, all humans should undergo some physical activity in the form of exercise. It is very, very beneficial. This action is independent of insulin. Exercise upregulating GLUT4, thereby decreasing blood glucose levels. Simple. Next. What will be seen during rapid ascent to high altitude? A very important question. There is also consequence for this. That important change that is seen during rapid ascent to high altitude is definitely respiratory alkalosis. Yes, sir, respiratory alkalosis. How is this happening? A very simple explanation. Remember, the concept now we are going to discuss will not happen in someone who is living there for years. People living in high altitude usually gets acclimatized. It is the newbies as a part of hobbies who have trekking, go to high altitude, what they have to be very, very careful. The starting point in high altitude is always hypoxia. You need a compensatory change for this hypoxia. This hypoxia activates our peripheral chemoreceptors, thereby stimulating ventilation. It's a form of hyperventilation, leading to carbon dioxide washout. Remember, fall in PCO2, his friend level will also decrease, fall in H+. So we are encountering an alkalosis. The cause for this alkalosis lies in lung. That is why we call this as respiratory alkalosis. It's a state like alkalosis, respiratory alkalosis. Now, two very good friends competing for a single thing. Who are all they? It is the H+ ion and the calcium competing binding sites for albumin. Whenever there is low levels of H+, respiratory alkalosis, low levels of H+ ions, more amount of calcium can bind to this albumin. So which form of calcium will rise here? Calcium bound form is increasing, correct? Because H+ ions are not there. Lot of calcium is getting bound to albumin. So calcium bound form is increasing. Correspondingly, the free form of calcium decreases. So this can lead to a state, this is the consequence, hypocalcemia, which can be they are more prone for tetanus. Very important. Respiratory alkalosis, calcium bound form increases, calcium free form decreases. When the free form of calcium, which is the active form, that decreases, it can lead to hypocalcemia and further it can lead to tetany. You have to keep this in mind. So high altitude, respiratory alkalosis. Simple. Next question. A patient presents to the outpatient department with fever. Which area is most likely involved? See, temperature regulation, obviously it is going to be about the hypothalamus. There are many options here concerned with hypothalamus. But what is the single best answer present in the anterior region of hypothalamus? It is none other but the preoptic nucleus. The answer for the question, definite answer, no doubt, it is preoptic nucleus. You, me, everyone watching this video definitely had this illness, which is fever. We all know this, fever. But always remember physiology first. This fever is a form of a body's defense mechanism. First and foremost, when there is a rise in temperature, body's defense mechanism is always enhanced. Fever. Now, most important, but I told you hypothalamus, it is the hypothalamic set point that is altered. Very important. Who is going to alter? Remember, any agent that is capable of causing fever, we call them as pyrogens. Definitely. They are going to affect which group of neurons? Heat sensitive neurons which are present in the preoptic area, in the anterior region of hypothalamus, preoptic nucleus. This heat sensitive neurons, their activity is altered. Hypothalamic set point is altered. I told you the area is definitely preoptic area. Most important question, sir. All the pieces of the puzzle we got except only one main agent, molecular agent, who is actually responsible for altering this set point. It's a prostaglandin, that is prostaglandin E2. So pyrogens, prostaglandin E2 influence the activity of heat sensitive neurons in preoptic area. Hypothalamic set point is altered. Fever. Very important. The answer for the question is preoptic nucleus. Next. The hyponatremia in a hypovolemic patient in case of severe diarrhea is due to severe diarrhea. We all know there is potential hyponatremia, hypovolemia. The answer for the question is definitely increase in secretion of ADH. We'll have a discussion and come back again to this 4 options. Now, what is diarrhea? What is actually happening here? There is loss of fluid, loss of electrolytes. In the question they have given severe diarrhea, that means they are more prone for 2 important things. First is hypovolemia, second is hyponatremia, loss of water, loss of sodium. This hyponatremia, remember, there is enhanced excretion of sodium in the feces. So correspondingly, there is a decreased absorption of sodium from the GIT. There is one option in our question. Decrease in sodium absorption from GIT, a very potential candidate for answer. Yes, I agree. Decrease in sodium absorption from GIT. So there is hyponatremia. So there is a disorder here. Body is always interested, system is always interested in the balance to maintain homeostasis. 2 systems are going to get activated. The first one is obviously the RAS, renin, angiotensin, aldosterone system, rise in aldosterone, which conserve sodium from the kidney. What it does, very important. Increase in sodium reabsorption from the kidney. There is hyponatremia. So aldosterone is conserving sodium. This is the first important compensatory mechanism. What is the second one, sir? Increase in antidiuretic hormone. There is water conservation. So body by itself is trying to treat these 2 disorders. There is hypovolemia. I conserve water with the help of ADH. There is hyponatremia. I try to conserve sodium with the help of aldosterone. So there is one option, increase in ADH. We are choosing this as option. Why? Because this increase in ADH, water conservation, can itself cause something called as at times dilutional hyponatremia. This increase in ADH, water is conserved by itself, can cause dilutional hyponatremia. So we have 2 correct answers here. Decrease in sodium absorption from GIT, increase in ADH secretion. We'll go to that question. Just 1 minute. Yeah. Decreased absorption of sodium from the gut is there. Increased secretion of ADH is there. We are choosing option D as answer. Keep a note this in mind. Few students mentioned there was an option decreased ADH. If the option decreased ADH was there, then the best answer becomes decreased absorption of sodium from the gut. Majority of the students told me the option was increase in ADH. If increase in ADH was there as option, then definitely increase in ADH should be the answer. On the other hand, few students told there was decrease in ADH. If there was decrease in ADH, then you have to choose this option B, decreased absorption of sodium from the gut. That becomes answer. But majority told the option was increased ADH. So we are choosing increased secretion of ADH as the answer here. Next question. This we had a very interesting discussion. Next. Many questions from ADH this time. The second question, the ADH action leads to concentrated urine by all of the following mechanisms except. What do you think? We all know definitely water conserving is an important action. Next important thing, remember, we are always interested in something called as medullary hyperosmolarity. If you take this as 100%, 50% contributed by sodium, remaining 50% contributed by urea. ADH aid this medullary hyperosmolarity by reabsorbing urea, by reabsorbing sodium. So anything concerned with sodium here, increased reabsorption of sodium from the thick ascending loop of Henle, yes, ADH does this. Increased absorption of urea from the medullary collecting ducts, yes, ADH does this, but no action on descending limb of loop of Henle, that's all. ADH conserves water, true. It aids in development of medullary hyperosmolarity by reabsorbing sodium and urea. Because sodium contributes 50%, remaining 50% by urea. Both their reabsorption are enhanced by ADH. But this action of urea is at the medullary collecting duct. It is not at the level of descending limb of loop of Henle. So, except, so definite answer for this is option A. Simple. What is the next question? Which of the following pulses can be best explained by Frank-Starling law? A very beautiful question indeed. No doubt the answer is pulses alternans. I'll show you the picture. A pulse waveform recording. How this pulses alternans look like? Very clear. What are you observing, guys? A strong pulse, a weak pulse. A strong pulse, a weak pulse. Alternating strong and weak pulses. We call this as pulses alternans. First question. What is the most common cause for this pulses alternans? It is usually seen in patients with heart failure. Heart failure, left ventricular dysfunction. True, that is the starting point. Yes, sir. Reduced left ventricular contractility, you definitely get a weak pulse. If there is a reduced left ventricular contractility, what happens to stroke volume? There is decrease in stroke volume. Less is going out, more is staying inside the heart. Less is going out, decrease in stroke volume. More is staying inside the heart, increase in residual volume. This increase in residual volume is reflected as increase in end diastolic volume. So this increase in end diastolic volume is going to cause stretch of ventricular wall. This stretch causing stronger left ventricular contractility, you are going to get a strong pulse. That's all. So alternating strong pulse, weak pulse. What is the very essence of Frank-Starling law? Now connect all the pieces together. The very essence of Frank-Starling law is increased end diastolic volume leading to stronger contraction and a higher stroke volume. Obviously, increase in residual volume, increase in end diastolic volume, stretch induced left ventricular myocardial contractility, strong pulse ensues. Strong pulse, weak pulse, strong pulse, weak pulse. Pulses alternans, Frank-Starling law. Simple. Next question. The murmur of mitral stenosis corresponds to which part of the ECG? Another thought-provoking question. Mitral stenosis, what murmur we classically get? Mid-diastolic murmur corresponds to P wave. How to remember this, sir? No need to memorize. Understand the concept with the help of this diagram. Always remember, guys, electrical activity comes first, mechanical activity comes next. Electrical activity first, action potential. Mechanical activity comes later, contractility. So the electrical activity is the QRS complex. The mechanical activity is the ventricular systole. The electrical activity is the T wave, ventricular relaxation. The mechanical activity is the ventricular diastole. What is the classical mitral stenosis murmur? We know it is the mid-diastolic murmur. It is exclusively during ventricular diastole, mid-diastolic murmur. That corresponds to which wave? Very obvious, sir. Mid-diastolic murmur, ventricular diastole corresponding to P wave. Simple. Next question. The neural center responsible for explicit memory. Memory, no doubt at all, hippocampus. Out of all the questions, which question I particularly love? It is this question, sir. Why, sir? Practical, real life example. On the day of exam, if I ask you, what you did? Sir, I woke up, I went to exam hall, I gave exam, then I came out, lot of Facebook groups, Instagram, YouTube, everywhere. We recollected questions, sir. We recall the questions, sir. Whatever happened, whatever questions asked, I remembered and I help in recall. See, I am doing the recall now. It is all because of you guys. You declared what was the question asked. You recalled perfectly what was the question asked. This recall is a form of explicit memory. This is what we call recall. Of events, I told you, your exam, how you went. Of facts, what are all the questions asked. This recall is also called as declarative memory. Explicit memory or declarative memory or recall based memory, definitely it is hippocampus. The answer is D. Simple. Now let's shift to the next question. What is this question? Yes, the Bezold-Jarisch reflex. Another chronic repeat topic. Bezold-Jarisch reflex typically leads to. It's a bradycardic reflex. We remember B. B for B, bradycardic reflex. So tachycardia is out. It can lead to bradycardia, hypotension, hypopnea, particularly in myocardial infarction. You see this reflex? Now, what is the answer for this question? Definitely, it is options A, B and C. It's a bradycardic reflex. The very essence of this Bezold-Jarisch reflex is parasympathetic stimulation. Here, parasympathetic stimulation happens. Sympathetic inhibition happens. Sympathetic nervous system is inhibited. So, the manifestations of parasympathetic stimulation, what are we going to see here? Bradycardia will be there. Hypotension will be there. Vasodilation will be there. Hypopnea will be there. So, what are all there in the options? Hypopnea, bradycardia, hypotension. It is parasympathetic activation, sympathetic inhibition. Bezold-Jarisch reflex. Simple. Bradycardic reflex. Next. During recording of EEG, a resting and awake person was instructed to close his eyes and then open them. The dominant wave which decreases on opening the eyes is. See, we all remember alpha waves. Eyes closed, simply relaxing but not sleeping. Eyes closed, simply relaxing. So, the wave of relaxation, the wave of a calm, relaxed state, it is always the alpha wave. What is the concept here, guys? Alpha waves are seen during eyes closed but relaxing. That is why we call this as a wakeful relaxation. See, we try to do this funny activity at times, right? Someone is simply closing his eyes and relaxing. We go near them and startle them like this. So, immediately they will open their eyes. What is that phenomenon called? Alpha block. That means the wave that is going to decrease now is alpha. When you become alert, when you are attentive, beta waves will come. Simply closing eyes, relaxation, alpha predominance. Startle them, open their eyes, alpha will get blocked, beta wave will come. So, what is the wave that decreases here? Definitely it is alpha wave. This is the classical alpha block. Alpha wave for wakeful relaxation. Closing your eyes, not sleeping, simply relaxing. Simple. The answer is alpha waves. Next question. Which of the following is an example of a feed-forward mechanism in homeostasis? See, in a twisted way, they always ask this question, feed-forward mechanism. Always remember, guys, the most important example is always temperature regulation. So, anything concerned with the temperature regulation here, vasoconstriction on cooling of skin. Other options, increased cardiac output in severe anemia, increased vasopressin secretion during dehydration, increased heart rate when standing up from supine position. All these are negative feedback mechanisms. Concerned with the temperature regulation, vasoconstriction on cooling of skin, feed-forward mechanism. So, option B is the answer here. A very important discussion. The answer becomes clear-cut now. Remember, feed-forward control is always temperature regulation. There are two important temperature. First is the shell temperature, that means our skin temperature, the peripheral shell, skin temperature. But the body is always interested in maintaining the interior temperature, that is the core temperature. That is the temperature around the internal organs. Core temperature is what hypothalamus is basically interested. What is given in the option? Skin cooling. Okay. That means the cell temperature is falling. Skin cooling. Skin temperature is falling. So the hypothalamus is anticipating now. Our hypothalamus is anticipating core temperature will fall. It will activate certain protective responses to maintain. Remember, that is the key word. Hypothalamus is anticipating feed-forward control. It is anticipating the core temperature will fall and activate certain responses to maintain this core temperature. What are these protective responses, sir? First is shivering. Second is vasoconstriction. So very obvious. On skin cooling, there is vasoconstriction because hypothalamus is anticipating core temperature is about to fall and give corrective measures by doing shivering and vasoconstriction. So it's a classical example for a feed-forward mechanism, temperature regulation, vasoconstriction on skin cooling. Simple. Next question. The surface tension of the fluid lining the alveoli increases during. Surface tension increases during inspiration. What is the explanation for this, sir? A very simple one, guys. See, this is the expanded alveoli during inspiration. See, alveolar expansion happens. Because of that, the surfactant molecules are wide apart. What I am saying, the surfactant molecules are wide apart. Surfactant concentration decreases. When the surfactant concentration decreases, what is the function of surfactant? To decrease surface tension. When the surfactant level decreases, obviously surface tension will increase. This classically happens during inspiration. How to view this, guys? Your alveoli is expanding. Surfactant molecules are widely spaced. Surface tension increases. This is putting a brake on further expansion of alveoli. Alveoli is expanding. Surface tension rises. Now it is putting a brake for further expansion. So surface tension increases during inspiration. This increase in surface tension is putting a brake on our alveoli for further expansion. That's all. Simple. Next. Tight junctions are present in which of the following epithelial domains? Again, it's a very tricky MCQ. Non-specifically, books mention apical domains, but the very specific best answer we will see from this picture. This is the apical membrane. This is the lateral membrane. This is the basal membrane. Where the tight junction is classically located? In the apicolateral. Very clear. It is located in the apicolateral part. The answer is not apical. We are clearly seeing in this diagram apical, lateral. It's exactly present at the apicolateral side. So the answer is definitely D. Tight junctions at the apicolateral junction. Next question. Which of the following molecules is structurally most similar to IGF-1 and IGF-2? Again, a very interesting question. The answer for this is not insulin. It is pro-insulin. They are structurally very similar to pro-insulin. What is the reference for this, sir? Very simple. How to find out the reference? Who discovered the structure of this IGF-1 and IGF-2? Very simple. Rinderknecht and Hummel. The scientist name is Rinderknecht and Hummel. Exactly, if I remember correctly, the year is 1978. They published their work in the Journal of Biological Chemistry. The exact title of that work is The Amino Acid Sequence of Human Insulin-like Growth Factor 1 and its Structural Homology with Proinsulin. Rinderknecht and Hummel. Remember the names? Rinderknecht and Hummel discovered the structure of insulin-like growth factors and they found they are structurally very similar to proinsulin. This is the title of their study, published in the Journal of Biological Chemistry in the year 1978. Always remember, guys, proinsulin, IGF-1, IGF-2. They are single chain polypeptides. On the other hand, insulin is a two-chain polypeptide. There itself we can exclude the answer of insulin. Proinsulin, IGF-1, IGF-2, they are single chain molecule, single chain polypeptide. On the other hand, a very drastic difference, insulin is a two-chain, dual chain. It has two-chain polypeptide. So IGF-1, IGF-2, their structures are more similar to proinsulin, which was actually told by the discoverers of its structure, Rinderknecht and Hummel, who discovered the structure of IGF-1 and IGF-2. Very similar to proinsulin. So these are all the 15 questions we got in the INI-CET, particularly in physiology. So according to me, around 11 to 12 questions are very direct, easily solvable, and around 3 questions always very tricky ones. But then that's part of the exam always. In any exam, 75% of the questions is what we are interested. If there are 10 questions, we want to solve 7 questions correct. Our preparation should be always towards 7 or more. That will get to a very, very, very good rank. Out of 10 questions, minimum you need to get 7 questions correct. 7 or more, that is the criteria. I think you definitely have done the exam very well. The information we learnt in physiology through Marrow videos would have definitely helped you to solve these questions. With that small note, my heartiest wishes, good luck and best wishes. Loads and loads of blessings, abundance of happiness are always there for you. Good luck and best wishes, guys. Thank you so much.